Okay guys, we are looking for the hemodynamic profiles in this patient here. So we have a 68 years old man presents with 2 hours of severe shortness of breath and chest pressure. He has a history of hypertension, hyperlipidemia and heavy smoking. Blood pressure is 78/50, pulse is 118. Physical exam shows jugular venous distension and bilateral beta crickles. An ECG shows ST segment elevation in the anterior leads. Okay, by the ECG here guys, we know that this man is mainly complaining of acute myocardial infarction. And also we have a signs and symptoms of acute heart failure. So this myocardial infarction is mainly complicated by cardiogenic shock. So to know the right answer in this case here guys, we will use this table. Okay guys, and this table here will make it easy for us to understand everything we need for cardiogenic shock and how to differentiate it from different type of shocks. The first thing is cardiac output. Okay, in cardiogenic shock we have a left ventricular failure, so we cannot pump enough blood into systemic circulation, so we will have a decreased cardiac output. Second thing is BCWP, which is pulmonary capillary wedge pressure. This one is a reflection of the left atrial pressure. So when we have increase in left atrial pressure, we will have increase in BCWP and the opposite, okay? Here in cardiogenic shock, we cannot pump blood, so the blood in left ventricle will accumulate. And this will lead to a backup pressure and increase in left atrial pressure here. So we will have increased BCWP. The third thing is SVR, which is systemic vascular resistance. Let's explain it here guys. When we have a decreased cardiac output, okay, this will activate the baroreceptors in our body, and this will activate two main systems. The first one is the sympathetic nervous system. This will increase our epinephrine. Second one is renin-angiotensin-aldosterone system, okay, and this will increase our angiotensin. And both of these guys are very potent vasoconstrictors. This will lead to a massive vasoconstriction in our body and increase in systemic vascular resistance to maintain our blood pressure. Okay? Second thing is hypovolemic shock. In hypovolemic state, we have decreased blood in all of our body. So we have decreased blood in left ventricle. So we will pump less blood to systemic circulation. So we will have decreased cardiac output. Second thing is BCWP. We have decreased blood in left atrium, so we will have decrease in left atrial pressure, so we will have a decreased BCWP. And also we will have increase in systemic vascular resistance by the same mechanism as in cardiogenic shock, okay? Third thing is obstructive shock. Okay, in obstructive shock we have two main categories. It can be cardiac or can be pulmonary. Okay, for cardiac cases like cardiac tamponade, we have fluid and blood around the heart. Our heart cannot pump easily. We cannot send enough blood to systemic circulation, so we will have a decreased cardiac output. And also in pulmonary cases like pulmonary embolism or intention pneumothorax, when we have obstruction at the level of the lungs, we send the blood from right ventricle, as you know guys, to the left atrium. Okay. When we have obstruction at this level here, so we cannot send enough blood to left atrium and left ventricle, so we can send less blood to the body. So we will have a decreased also cardiac output. But the real difference comes in BCWP, because for example in cardiac tamponade we have a fluid around the heart, and this fluid push on the muscles of the heart and push in the chambers of the heart. So in this case we have increased pressure in all of our heart chambers. So increased pressure in left atrium will lead to increase in BCWP, as we see here. But in pulmonary cases, like in pulmonary embolism or tension pneumothorax, we cannot send the blood enough to the left atrium. So we have decreased the volume in the left atrium, so we will have a decrease in BCWP. So it can be increased or decreased, okay. And we also have increase in systemic vascular resistance by the same mechanism as in cardiogenic and hypovolemic shock. Now guys, the septic and anaphylactic shock, okay. Septic and anaphylactic shock are different, because in this case the primary effect will be in systemic vascular resistance. In septic and anaphylactic shock, our body secretes some mediators like nitric oxide, like histamine, and these gather very potent vasodilators. So we will have a massive vasodilatation in our blood, and this will lead to a decrease in SVR. Okay, and by time and in later stages, when we have a severe vasodilatation, we cannot send enough blood to the venous return to the right side of the heart. So when we have a decrease in venous return, we can send less blood to the left side of the heart. So we'll have decreased blood in left atrium and decreased BCWP, and decreased blood in left ventricle. So we can send less blood to systemic circulation and decreased cardiac output. Now let's go back to our question to figure out the right answer. So we have choice A and choice B with decreased cardiac output here guys, okay? But in cardiogenic shock we have increased BCWP and increased SVR. This makes choice B is the right answer for our case today guys.